for this evening webinar. It's a very interesting webinar this evening. We are having two eminent speakers, Dr. J.B. Sharma sir and Dr. Ramani Devi madam, who will be speaking on the overactive bladder and the asymptomatic bacteriuria in pregnancy. These two are very important in our clinical practical perspective. So let us go ahead. And Mr. Arun, can I have J.B. Sharma sir's CV?
Sir, can we start with the prayer, sir? Starting.
Yeah,
Yes.
please.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
So our first speaker is Dr. J.B. Sharma sir. He is the professor and head of the department at Yashoda Medicity, Indirapuram, NCR. Sir is a very popular figure in the field of urogynecology among all the gynecologists. Sir has been awarded Dr. B.C. Roy Award by Honorable President of India in 2015 for research in obstetrics and gynecology, which is a very important the award for all the medical fraternity. And sir has got about 425 publications in indexed and non-indexed journals with 225 in peer reviewed indexed national and international journals. Author of the textbook of obstetrics and textbook of gynecology and midwifery and obstetrical nursing. Textbook of obstetrics is one of the popular textbook among the undergraduates throughout the India, written by Dr. J.B. Sharma sir. Sir has won Indian Council of Medical Research Amrut Modi Unichem Prize for his research work on anemia during pregnancy. Sir will be speaking on overactive bladder this evening. Over to you, sir.
Thank you. So, thank you very much, Professor Vijay Kumar. At the outset, I thank you and congratulate you for doing such wonderful work for Urogyne. You are so active. You deserve to be actually national chairperson, not only of one state, but of the whole country. Really, and I'm sure you will be. And respected Ramani Devi Madam, it's a pleasure to meet Madam, has been our senior, and I'm so delighted Madam did PhD recently. So it really speaks volumes about how keen is Madam. Madam. You got it ultimately, no, Madam? Yeah, thank you.
Thank you.
Yes, thank you. Please share it. Yeah. So thank you very much. So please, so the important topics will be there.
Sir,
Ramani Devi will be talking about UTI and I'll be talking about overactive bladder syndrome.
Just I want to interrupt you, sir. I just wanted to invite the chairperson of this
yes, please,
please, sir, please. For this talk, Arun.
Yes, sir.
Can we have the slides of the chairpersons?
Yes, sir.
For this, the first talk, I want to invite Dr. Ranganath S. as the one of the chairperson. Dr. Ranganath is one of my close friend since our post-graduation. Dr. Ranganath is a chief consultant and medical director at Asare Fertility Center, one of the very successful fertility center in Lingasuru. He is the currently president of Raichur Society of the Obstetrics and Gynecology, which comes under the umbrella of Kasoga. Dr. Ranganath has done MBBS from MMC and MS from the Bangalore Medical College, worked as a consultant in one of the leading IVF center, that is Craft of the Kerala. He started his Asare Fertility Center in Lingasuru since 2010, and it has become a role model center in the northeast part of the Karnataka. And he has presented various papers in national and UFOXY conferences, awarded Healthcare Excellence Award by the Asian Net Suvarna News Channel in 2023 and Basvasri Kayaka Award in 2023. I welcome you, Dr. Ranganath. One more chairperson is Dr. Vidya Vasudev Murthy, working as a consultant gynecologist at Vidya Hospital, Ranebennuru. Served as IMA president, organized health camps and awareness activities, and received a Best Branch IMA award and Best President and Diamond Trophy from Karnataka State IMA. Contributed to flood relief work in Madikeri and Bagalkot. Currently president of Haveri Obstetrics and Gynecology. Participated in several conferences and delivered health awareness lectures. I welcome you, Madam, Dr. Vidya Vasudev Murthy.
Thank you, sir.
Please, with your permission, we will go ahead with Dr. J.B. Sharma's talk on overactive bladder, Madam. J.B. Sharma, sir, please.
Yes, sir. So if
Yes.
someone can start my slides, Rand.
Arun, put on the slides.
One second, sir.
So thank you very much, sir, and respected chairpersons and respected Ramani Devi madam. So it is a pleasure to be here in this Karnataka Obstetric Society's conference webinar on a very important topic of overactive bladder syndrome. So while the slides are coming, so I mean, Dr. Ramani Devi will be speaking on UTI. So I want to share some common things between UTI and overactive bladder syndrome. In both the conditions, I mean, the symptoms may be similar. So, but in UTI, the urine culture will be positive. That means it will show bacteria. While in case of overactive bladder syndrome, urine culture is sterile. So, can I have my slides, please? Mr. Arun?
Arun?
Okay, yeah. So, thank you very much. The slides are there. So I'll be speaking about the overactive bladder syndrome. Next slide, please. So, yeah. So, overactive bladder syndrome is characterized by urinary urgency, frequency, nocturia, or also called urge urinary incontinence, and it without infection or obvious pathology. So, Dr. Ramani, they will be talking after me. The same symptoms are there in UTI. So, that means OAB, that means same symptoms in absence of UTI. So, if urine culture is sterile, patient is having urinary urgency, frequency, nocturia, then only we label it overactive bladder syndrome, and not like sometimes patient has got UTI, but we have given antibiotic, and then the culture may be sterile, though still it will remain UTI. So OAB is basically means without urinary infection and without any other pathology. If some patient has got stone in the bladder and then symptoms, again it won't be OAB. So the impact of OAB on quality of life is profound, we all know, and prevalence is reported as high as 27%. Frequency and severity of OAB symptoms tend to escalate with advancing age. And no proven or identifiable infection, metabolic or other obvious urethrocycle pathological abnormality should be there. Then only we label it. It just means bladder is overactive. At the time when bladder should remain relaxed, it starts contracting and patient passes urine in the filling phase of the bladder. Next slide, please. Okay, yeah. So the urgency, as described by Ayuga and ICS, is the complaint of sudden compelling desire to urinate, and which is difficult to defer. So is it just like sometimes when we reach our home and we are, trying to open the house with the key and the wrong key is there. At that time, some people pass urine. this is, so that is again part of urgency. And increased daytime frequency is also defined by Ayuga and ICS as the complaint that micturition occurs more frequently during waking hour than deemed normal. Same way we have nocturia, that means frequency is more in the night. Once everyone gets up in the night, more than once usually, but especially 3 or more times if one has to get up in the night, then we label it nocturia. And it affects the sleep naturally. Next slide, please. Okay. So nocturia is the complaint of interruption of sleep 1 or more times because to micturate, and each word is preceded and followed by sleep. So like daytime frequency, nocturia is a multifactorial symptom which is often due to factors unrelated to OAB. And so it is also important to realize that sometimes, like even I have that. So suppose I'm getting up, I got up some, say at 2 o'clock in the night, just got up and then I went to washroom. And then I got up at 5 o'clock and I went to washroom. So that is not nocturia. That is because I woke up. So some people are having actually like difficulty in sleeping or sleep issues. Then they go to washroom. That is not nocturia. Nocturia means they have to get up from the sleep to pass urine. Well, so urge urinary incontinence is other name for overactive bladder syndrome. It's complaint of involuntary leakage of urine associated with urgency. Okay, that means sudden compelling desire to void. And incontinence episodes can be measured reliably with a diary or by self-report, and quantity of urine leakage can be estimated with pad count. So that is important that we can keep a small diary. You don't have to have the 1 week diary, which is generally recommended. In Safdarjung Hospital in Delhi, they have developed a weekend diary. So you can do for 48 hours, like we can keep how much fluid she is consuming. On the other hand side, we have how much time she passes urine. So we can calculate. And that is very important. Will come in the subsequent slide also, because sometimes some people are drinking too much of water. I had at least treated 4 or 5 patients, Professor Vijay Kumar sir, in which when we did the diary, patient was drinking 4.5 liters of water or other drinks every day. This concept is going on that if you drink too much of water, your face will glow like Katrina Kaif or Alia Bhatt. That is not true actually. So the effect of water on facial glowing is doubtful, but effect on the bladder is real. So all of us need 1.8 to 2 liter of water for our kidney function, renal function. More than that, we should not drink. So that is very important. So simple bladder diary can help us. And when we ask those patients to drink less water without any treatments or no treatment was given, they became all right. So they were having too much, they were drinking water. Next slide, please. Okay, so incontinence is necessary, not necessary condition for diagnosis of OAB. Approximately 2/3 of the patient with OAB do not have incontinence, but they may have symptoms. Like we can have OAB wet when the patient has incontinence. That means she has compelling desire to pass urine and she passes urine, so we call it wet. But she has compelling desire to pass urine, even if she not able to, she hasn't passed urine, so we call it OAB dry. So even the symptoms suggestive of frequency urgency are also troubling her. So we call it OAB dry, and even that needs treatment. So even without leakage or without wetting the clothes, it can be a problem in some patients. Next slide, please. Okay, so prevalence of OAB varies, and it can be up to like in more than 40 years of age. Usually as the age advances, most urogynecology problem increase more in the elderly age group, and after 40 years, so almost 16%, 16 to 17% patients, that means 1 in 6 patients have got OAB. And most commonly reported symptom is frequency, almost 85%, followed by urgency, 54%, urge incontinence, 36%, and overall 60% of respondents with symptoms consult a doctor, but only 27% receive treatment. So you can imagine that is the, just like in hypertension, we have that rule, no? That so here also 60% don't consult a doctor, and those who consult also only 27% receive treatment. So there is this, like somewhere lacuna this thing, and all urogynecology problem. I think all of you agree with me. A lot of patients think that it's a part of normal aging, so they suffer in silence. So that is not true. Actually, many of these conditions are totally treatable, and they don't have to suffer in silence. They are not part of normal aging. They are abnormal. We need to treat them. Next slide, please. So what physiology is, we know that control of micturition includes the sympathetic and parasympathetic system under the control of higher centers, including the brainstem, pons, and cerebral cortex. And the sympathetic is inhibitory. So like while I'm delivering this talk, now my sympathetic system is working and it is inhibiting. Okay, well, parasympathetic S2 to S3-4. Sympathetic is T10 to T10, 11, and to up to L1. So parasympathetic is from simple, you can say in passage. P for parasympathetic, P for passage of urine. So during, like after the end of this lecture, I'll go to washroom. So at that time, sympathetic system has to take a back seat. Parasympathetic system will come into play, and then through S234 function, it will contact the blood detrusor and it will relax the urethra. Then only pass urine. So while sympathetic has opposite effect, and then even if like I'm trying to pass urine, so and this is responsible for muscarinic receptors M1 to M5, but predominantly M3. This is important to know because M3 receptors antagonists are the drugs which are used for urge incontinence, these symptoms, like the deriphenacin, sulfaphenacin, which we will be discussing. That is important. So that is important that the sympathetic is inhibitory, parasympathetic is stimulatory or helps to pass urine. Next slide, please. Pudendal nerve also helps there. Yeah, the same thing basically shown here. So pontine maturation center is there, and then it stimulates the parasympathetic nerve through pelvic nerve S234, while T1, T10 to L2 sympathetic hypogastric, that so sympathetically inhibit the detrusor, relax and contract the urethra. Okay, so we don't pass urine, while parasympathetic will contract the bladder and relax the urethra. Pudendal nerve still can act at the level of urethra again. Next slide, please. So, yeah, okay. So same thing about the receptors we have said. So M3 receptors are most important receptors. So we need to something to inhibit those receptors with the drugs, and that's how the detrusor muscle tone will be sort of reduced and this thing, because detrusor contracts during the filling phase, patient passes urine. So we have to relax the detrusor at that time. That is how it will work. Next slide, please. The role of neurotransmitters. Yeah. So yeah, same thing. We can go to the next slide, please. Yeah. Okay. So diagnosis is mainly based on history and symptoms. You don't have to do a urodynamic study for every single patient. Mild to moderate cases, you can easily treat only on the basis of history and symptoms. And investigation to rule out any other infections, organic structural etiology may be carried out. A simple urine, Dr. Ramani Devi, madam, will be covering after me. So urine examination, including urine in like microscopy, as well as for albumin, sugar, and for culture is to be done, and if that is negative, then only we label her as overactive bladder syndrome. So urodynamics are not necessary for diagnosis of this thing, but they, if we do them, that definitely they will show evidence of detrusor overactivity, and but that may be seen only in 40% cases of urgency. So that means even by doing urodynamic study, some cases of overactive bladder syndrome can be missed. But how the urodynamics will help us? I mean, when during the filling phase of the bladder, during you doing urodynamics, detrusor should remain relaxed in the filling phase. So if there is detrusor overactivity during filling phase, then the detrusor will contract, and basically the urine will go opposite. Basically, it will flow back from the bladder towards the drip, which should not happen. So that is what it will be shown on detrusor overactivity during filling phase. That is shown on urodynamic studies. But otherwise, also from symptom sign we can diagnose. So you don't have to do urodynamic study for every single patient. In complicated patient, mixed incontinence, failed cases, and all, then we should do, or before we are venturing for the difficult sling surgery and all, then we should do urodynamic study. Simple, straightforward OAB, you don't have to do. Straightforward SUI, you don't have to do. You can even do surgical treatment also. That is American College of Scanning guideline. But complicated patient, medical legal issues, previous failed surgery, sling surgeries and all, then it's better to do urodynamic study. Next slide, please. Okay, so urodynamic study is useful for patient with suspected, this. I told you underactive detrusor, SUI, symptoms, mixed urinary incontinence, or any worse symptom, lower quality of life. So I have already discussed this topic, like failed surgery, difficult, complicated case, or sling surgery we are predicting, and failure of the medical therapy also you can do. Yeah, next slide, please. Not in every single patient. So straightforward patient we can treat directly also. Next slide, please. Okay, so these are the various causes and all. So basically we need to do in history taking urological history, gynae history, neurological, medical, surgical, social, psychological, radiation, pelvic trauma. So I want to spend a minute on this slide. Basically, so what I want to highlight to my esteemed delegates who are attending the seminar, that in the case of urogyne, Professor Vijay Kumar sir will agree with me that please do spend more time on these ladies. They are mostly elderly ladies or in the beyond reporting age group, but some can be young also. So they, people don't have spoken to them. They are hiding their symptoms. So we need to spend more time on them. On an average, I spend about half an hour on a urogyne patient. And then we need to take detailed history, including neurological history, including their fluid intake, including any drugs they are taking. And let me tell you, I have found at least not once, but 50 times, sir, I have found, new things which were missed by my other colleague. I had a dentist, sir, she came to me, she didn't have any sensation in that area. And she had urinary symptoms, and she said, sir, you put a tape on me. I mean, she had symptoms of both SUI and adorable bladder syndrome. So when I went into this, she was born with meningomyelocele, for which she was operated in childhood. So in that case, had it done a tape for her, it would have been a disaster. Another patient had multiple sclerosis, and then she had urinary incontinence. So those are the conditions because related to that. Then some patients are on antipsychotic drugs. Some patients are on diuretics. Our physician colleagues and cardiologists are very fond of giving diuretics for hypertension patients because diuretics are like important drugs for them. So some, sir, at least I have treated 10 patients just by changing their drugs from diuretic to ACE inhibitor and all. I not myself. I just recommended that if can we stop diuretic, and then when they were given new drugs, then they got better. So this is basically so detailed history taking of any past surgical history, the drugs they are taking, any social history, and the fluid amount they are taking, any radiation. I had patient radiation cystitis, sir. The patient had radiation therapy for carcinoma cervix in past. So that makes the bladder very shrunken. I had a patient of thimble bladder. Thimble bladder, that means bladder was very much constricted because of the tuberculosis. So those are the conditions where, which themselves can cause this trauma, and pelvic trauma, of course. So detailed history taking is very, very important. Next slide, please. Okay. Okay, can we have the next slide? Yeah. Okay. So incontinence history again, what is the characterization of incontinence? What is the length and severity of symptoms? How long? 1 year, 2 years, 3 years? What is the impact on quality of life? And what are associated bowel problems? Because sometimes the childbirth trauma can cause both urinary incontinence as well as bowel incontinence. So we have to know that also. Quite often I see patients of concomitant prolapse vaginal, like uterine prolapse, cystocele, lactocele, along with rectal prolapse also. So this is very, very important to know the effect on quality of life as well as associated bowel symptoms and how long it has been suffering because of that. Next slide, please. Okay, so then we need to do complete physical examination, which include neurological examination. So I have written the lower half: mental status, mobility, lumbar and sacral sensory motor. Now, as I told in that case, BC reflex, swing, knee, ankle, detail. So detailed neurological examination, including cranial nerve examination, is important for a case of urinary incontinence. As I told you before, in the condition where the neurological condition can also cause urinary incontinence. Quite often I get patients, like recently, patient had pelvic trauma, and then because of that, or one patient had a spinal cord injury. So all those patients will be having urinary incontinence. So they are beyond the scope of this lecture. Then systemic vaginal and pelvic examination, condition of mucosa, urethral mobility, demonstration of incontinence, vaginal prolapse, anterior, posterior, apical, bimanual examination. So quite often patients of cystocele, especially large cystocele, tend to have frequency nocturia, and because the bladder gets static there, so they are more prone to have urinary infection, and because of that, they may have urgency frequency nocturia. So that will be, and bimanual examination for any mass in the pelvis. I have seen, sir, 2-3 patients. There was a large retroperitoneal mass in one case. It was pushing everything down, and the bladder was as if it will burst one day. And then when we had to do laparoscopy to remove that, and after that, patient became all right. So even without, so there was no need to do cystocele for that patient. Next slide, please. Yeah. So then we have to do voiding and intake diary. So extremely important, especially in case of overactive bladder. Then incontinence diary. So urine analysis, I have already said urine culture, cytology, madam will also discuss about it. Post-void residual urine and PET test. So this is very important. I have already discussed about the role of that we can keep a simple weekend diary, sir, very convenient for the patient rather having a full week diary. So in that, patient will report everything she drinks, whatever fluid she is drinking. Tea, coffee, beverages and water. So total how much she takes. And I discussed before also that about 5% I have found where they were drinking 4 liters, 4.5 liters, 5 liters. So just by reducing the fluid intake, the patients became all right. So that will help us. And then how much time is the incontinence? What time? Some patients have in the midnight, some patients have daytime. So we have to find out that. And of course, urine analysis and post analysis. PET test will help us just to confirm that patient has got some incontinence. So that means what we do, we give the pad to that is for very minute, sometimes just a drop or 2 drops of urine come, which may not be picked up otherwise. So here we give a pad, so 10-gram pad is given to the patient, we wait before, and then we ask the patient, we give her some drink, 500 ml or drink to the patient, and then she walks for about 10-15 minutes, wearing a pad. And that after half an hour, we weigh the pad again. I give this thesis to one of my PGs for some part. So then if the pad weighs more than 1 gram extra, like it was 10 gram before, now it's 11 gram. So that means there is 1 gram leakage in that. So normally in a healthy patient, like it will be negative, pad test will be negative. So pad test can tell us about the incontinence. Next slide, please. For mild incontinence, gross incontinence, you can grossly see. Role of cystometry is very limited. I told you that defining underlying pathophysiology for bladder filling phase, any involuntary detrusor contraction. I told before also, during bladder filling phase, detrusor should remain relaxed. It should not contract. So any detrusor contraction during filling phase of the bladder shows that it is a case of overactive bladder syndrome or basically urge incontinence. And then we can also see other pathologies on cystometry, and it's like low bladder compliance, urethral obstruction, impaired detrusor contractility, and it can help us in directing treatment also. So for complicated cases, it is of useful use. Next slide, please. Okay, so then now why to treat? So because patient is having physical, social, sexual, psychological, and occupational impact is there of the overactive bladder syndrome, it needs to be treated. It affects their quality of life. Patient is very depressed. I have seen patients, including a doctor. She herself was a consultant anesthetist, and for 2 years she hadn't attended any party, any marriage, and any function. She was so much depressed because she said she would leak. And I have seen another thing, sir, Professor Vijay Kumar, sir, it is not written in any books. Some of my elderly patient, at this age, the most important solace they get in life is the puja, prayer to God. And there is a concept, just like menstruation, with menstruation, the puja gets bhang. So same way, if they urinate or if they micturate or urinary incontinence, puja gets bhang. So that is not written in any book. And if you deprive an elderly human even of puja or like prayer to God, what is left in her life? So patient becomes so depressed, he wants to die. So we can do a lot for these patients. And then it is associated with comorbid, such as urinary tract infection, sleep disturbance. A patient who has to get up 4 times in the night, how can you expect her to get up in the morning? How can you expect her to remain fine in the daytime? Then depression and poor quality of life of these, almost 32% patients stated that these symptoms made them feel depressed, and 28% reported them as a source of stress. Just I told about this anesthetist colleague of mine, and ever since I treated her now, after that, so she attends all this. She attended her daughter's delivery in USA. From there, she rang me. She's much better now. So you can do a lot for them. The elderly are also at increased risk of falls and fracture from rushing to the toilet. So this is very, very important, sir, because suppose she's a 72-year-old lady going to the washroom, and one of my patients gave, she fractured her, the head of femur. And if there is a head fracture of head of femur, you can imagine the life of that patient. Some patients die, others become crippled forever. And so if they have to go 4 times in the night, you can imagine the chances of falling and fracturing are much more. So we have to think of that also. So that's why it is mandatory to treat these patients. Next slide, please. Okay. Yeah. Next slide, please. Okay, so management, what is the management? The good thing is that for overactive bladder syndrome, usually no surgical treatment is required. For SUI, surgical treatment is the treatment. Here, medical treatment is given. So, single most important is first we do lifestyle changes, weight reduction. Many of the patients of overactive bladder syndrome are obese or overweight. So, that's a good idea. We need to ask them that you need to reduce 2 kg weight in next 3 to 6 months time gradually. Don't say, we can't, nobody can lose 5 kg in 1 month. It's not impossible. So we give gradually, and that helps. One of my patients, she was, she had severe overactive bladder syndrome, and she was 85 kg. Her real sister lived across the road. She had not visited her for last 3 years. So when I treated her, and then she lost 2 kg weight, and her knees also were cracking. So then there was a sort of glow in her face. She says, "Sir, I want to lose more weight." She lost 2 kg, and then she lost 3 kg. Her symptoms became better. Of course, I gave her other treatment also. And then avoid caffeine and smoking. This is very important. And we need to find out, sir, there are 2 types of fluids. Bladder friendly fluid, bladder enemy, or you can say causing incontinence or irritant, bladder irritants we call them. I learned that in King's College London when I was there last year. So, but so and that may differ from patient to patient. Like for me, it may be tea or coffee. For someone, it may be Coca-Cola. For someone, it may be some other fluid. But there's some there's some bladder-friendly fluid like this. We can say cranberry juice, some juices, coconut water may be good for actually bladder. So we need to find our own this thing. But definitely tea, coffee, smoking, they are the harmful bacteria. I offered a cup of coffee to my professor of ophthalmology from a medical college in Delhi, and he refused. He said, I had one cup of coffee and I went to washroom 10 times in 1 hour. I said, how can that be possible? So, but that he said, no, I can have tea. So that was very interesting. So I mean, everyone has their own this thing. So we need to find that, and they can reduce tea and coffee accordingly, or like decaffeinated coffee can be had, or less severe coffee or tea can be had. Then physical therapy, normally Kegel exercises are more useful for stress incontinence, but they have wonderful role for overactive bladder syndrome also. And I tell my patients that exercises are good for health; they cost nothing. So in fact, all of us should routinely do pelvic floor exercises and abdominal wall exercises to prevent. My friend Professor Dr. Abdul Sultan from UK, he says perineum, either we use it or we lose it. So let's use it, and so that it becomes better. So it improves urethral closure and pelvic organ support. Strong contraction compresses urethra against symphysis pubis and prevents urethral kinking. Pelvic floor muscle training is consistently better than no treatment or placebo. Biofeedback, no additional benefit, but if you have the facility at your hospital, then you can give it. It just helps us to contract the right muscle. Electrostimulation also mixed result, but biofeedback, electrostimulation are not mandatory. But if you have them in your clinic or your hospital, then they can just help, because sometimes patient may be contracting only the anti-abdominal wall muscle, not the proper muscle. So that we need to tell them when we are doing vaginal exams. I ask the patient to squeeze my fingers, and then so that they in the beginning they are contracting the wrong muscles, abdominal muscles only. But gradually with experience, then their muscles become stronger. And then is the bladder training. So bladder training is nothing but training the bladder. So what I tell my patients that timed passage of urine. So what I say that in the morning, first week, I mean, I ask her how many hours you can hold on. So suppose she can't hold on even with 2 hours, then we can start with 1.5 hours. Otherwise, 2 hours. Like suppose she gets up at 6 o'clock, everyone has to go to washroom at 6 o'clock. So 6 o'clock, 8 o'clock, 10 o'clock. And plus I will be giving her some drug also, pelvic floor exercises also, and decrease tea, coffee and water. And next week, 6 to 15 minutes extra, sir. Next half an hour, 15 minutes. So like that, like 2 hours 15 minutes next week, 2.5 hours next week, then 2 hours 45 minutes, then 3 hours. So in a month or 6 weeks, I want to go to 3 hours, which is good enough. So that is there may be an occasion when patient leaks urine. I mean, it's okay. She can just change her clothes, but aim is to increase the capacity of bladder. So bladder is a very compliant organ. We can increase the capacity. And to make it simple for my patients, sir, I don't know, you may laugh at it. I tell my patient that, you may a little bit of Hindi, sir, that your bladder has forgotten its power. Just like Lord Hanuman had forgotten his power, he had to be reminded. So same way your bladder has forgotten its power, we have to remind it. So by bladder training, we do that. And that bladder is a very compliant organ. It's just like a balloon full of water. So we can increase it. Like in Holi, we increase the balloon. So same way we can do that. So this will work for 80-90% patient, but only 10 to 20% patient, if there is like radiation cystitis bladder, thimble bladder, constricted bladder, then automatically it will not work. So that those are special conditions. I mean, normally they are not there. So next slide, please. So this bladder training will also help. So next slide, please. So now it's the same thing. We have already done that. So lifestyle modification basically means lose weight and drink less fluid, less coffee, tea, and bladder-friendly fluids, and empty your bladder before going to sleep. And always empty your bladder completely, and empty your bladder before and after intercourse. Reduce your caffeine intake. Drink bladder-friendly fluid. I have said. Avoid going to bathroom just in case. Yeah, many times we have nothing else to do, so let me go to washroom. Don't do that. That will decrease our bladder capacity. But don't delay it also too much. Sometimes if you don't go to washroom for 3 to 4 hours, 5 hours, that also is bad, because that will put pressure on the nerves of the bladder, and sometimes the nerves may be damaged by that. So don't do that also. So 3 to 4 hours is a good time. Next slide, please. Okay. Yeah. So this bladder training I have already said, sir. So that's the time passage of urine and by clock. So every week we increase by 50 minutes. So ultimate aim is to 3 to 3.5 hours. Next slide, please. Okay. And Kegel exercise, I already said that, so they have to contract the right muscle. So preferably what I tell my patients are twice a day, 15 minutes in morning, 15 minutes in the evening, and try it for at least 3 months before seeing it has failed. So minimum 6 weeks, preferably 3 months. And it can be then continued forever. Exercises are good for health. In fact, I routinely do exercises, while in fact at the daily red lights, we have, I think, horrible red lights in Delhi all the time. I think that must be same in Bangalore also. So that is like, at red light, I contract my abdominal and perineal muscle. So though I'm thankful to daily red lights, they are making my perineal muscle and abdominal muscles better, keep me in fit states. Yeah, next slide, please. And Cochrane database also say they are useful. So biofeedback can be used along with that. Next slide, please. We have done that already. So there is no extra advantage of biofeedback and all, but they will help in strengthening the muscles in the lower pelvis. Electrical stimulation, same thing, so that we contract the right muscle, but they are not mandatory. Simple pelvic floor exercises, Kegels, can be taught to the patient. Next slide, please. Similarly, these days, these like chairs are available, like, in the market and all. So they also do the same thing. But it's not that if our patient is poor, she cannot afford sitting on that chair, so that she will not be helped. The simple, pelvic floor exercises will help. But definitely these chairs, I have nothing against them. There is no scientific evidence to prove they are superior. But definitely those who are having those chairs, they are expensive, patient can afford, then definitely they will help in the contracts. They do the same thing basically. So, and then, but patient will require one drug also. So till now, I have said that patient loses weight, number one. Number two, see time passage of urine. Number three, see a decreased tea, coffee. Number four, see a decreased water intake, fluid intake. And now I have to give her one drug, anticholinergic drug. So they are the key therapy which have inhibitory effect on sphincter. And so tricyclic antidepressant like imipramine are not used these days. The only role of imipramine which I use, sir, is the patient of nocturnal enuresis. Some girls or children, they have nocturnal enuresis, they pass urine in the bed. So there is the only indication 25 milligram imipramine can be given for 3 months or so. But that is the separate chapter. I won't discuss that today. And then otherwise, normally in the case of overactive bladder syndrome, we are not using it anymore. Sympathomimetic estrogen don't work that much. Botulinum toxin selected patients only when we inject it locally. Next slide, please. But mainly I want to discuss what the next slide, please. Anticholinergic drugs. So they decrease the detrusor activity, because what happens in filling phase detrusor contact. So we have to decrease that activity, and they abolish involuntary detrusor contraction, increase volume at which they occur, and increase compliance. So increase the bladder capacity and decrease the detrusor contraction, and they increase bladder capacity. Commonly used agents focus on inhibition at the end organ level, bladder level. Next slide, please. Okay, so antimuscarinic, which work at M3 receptors, are the main drug of choice, and they will inhibit bladder contraction. Acetylcholine from a cholinergic nerve stimulation muscarinic receptor. They block stimulation of muscarinic receptor. But the side effect is that they cause dry mouth, and they can cause constipation. Sometimes they can cause drowsiness and somnolence and blurred vision or dry eyes. Another thing I want to say that if we give them for many years, say 4-5 years, and elderly age group like 75-80 years of age, so sometimes they can cause cognitive dysfunction. Dr. Rani Thakkar was discussing, she gave us a lecture on this. So, but most of the patients are not that age group, and we are not giving them for 5 to 10 years, that also in 80 years of age group. And for that also, no, because an 80-year-old woman will anyway have cognitive dysfunction. So some people believe that it is normal part of aging, may not be related to antimuscarinic, but it is a good idea not to give them for 5 to 10 years and in 75 or 80 years of age group. And after 2 years, I give drug holiday to all my patients. Yeah, next slide, please. So this is, so this slide, oxybutynin was given, but I'm not using it anymore because it causes more dry mouth and effect is moderate. But now transdermal 3.9 milligram oxybutynin is available in UK, not in India yet. That works very well. So, but I personally am using derifenacin or solifenacin. So for my dear esteemed colleagues who are attending, so I start with derifenacin, available 2-3 brand name, Dairy Long, Dairy Task, couple of companies are coming, or you can just write derifenacin 7.5 milligram OD at about in the evening 5 o'clock they can take. So it will work for 24 hours. It does cause dry mouth, but not that much, and constipation. So then, but I can increase the dose to up to 15 milligram a day. But only the issue is that if you go to increase the dose, then patient may stop taking because of more dry mouth and constipation. And one contraindication will be narrow angle glaucoma. We should not use it. So same way, equivalent dose of derifenacin is solifenacin is 5 milligrams. Equal effect of both of them. So I use these mainly derifenacin, and toltyrosine 2 milligram is an older drug, can be used. But mirabagrone, another drug I want to highlight, so that is 25 milligram, and maximum dose we can go 50 milligram. But it is to be avoided in cardiac patients because it is beta 3 adrenergic drug. So for my dear esteemed colleagues here, if the patient has got narrow angle glaucoma or excessive dry mouth and all, in those patients, I give mirabegron as a drug of first choice to 25 milligram once a day, sir, up to, and I assess the patient after 3 months. But the patient has got patient is a cardiac patient, then avoid mirabegron. In those patients, I give derifenacin or solifenacin, 75 milligram OD, and for 3 months. So in my practice, sir, 70% of my patients of overactive bladder syndrome are on derifenacin, 7.5 milligram a day. 20% patients are on mirabegron and 10% patients are on combinations. If the drug is effective but not that much, then I combine the two and the patient did not have cardiac disease or patient doesn't have narrow angle glaucoma. So then I can combine the two. Other option would have been that I go to 15 milligram derifenacin, but that side effect will be high. Same way, mirabegron I can go to 50 milligram, but then the side effect will be more. Cardiac effect can be there. So instead of becoming too greedy, let's give them moderate dose and we can combine the two. And what I do, sir, I give this treatment, all this treatment for 2 years. I mean, and I assess them every 3 monthly. Don't see them every week or 2 weeks unless you want to earn too much of money, because give some time to the bladder to act. And sir, after 2 years, I give them drug holiday for 3 to 6 months. So I hope by in 2 years, patient has lost 3 to 4 kg weight. Patient is drinking less tea, coffee. Patient is drinking less water. By pelvic exercise, her muscles have become better. And by bladder training, her compliance of the bladder has become better. So by 2 years, so these other 4, I mean, there are 5 treatments. Drug is only one. So other 4 parameters, that's what I tell the patients, sir, that it, Mataji or, Banji, 80% work you will do, 20% my drugs will do. So you have to do more work. And now, so the drug will help then. So, but aim is that other 4 things have taken effect and that can be continued. So after 2 years, sir, I give them drug holiday of 3 to 6 months. I see them after 3 months. So like suppose 10 out of 10 patients, sir, where I stop the drug, 6 patients are okay, but 4 patients come back. They say, sir, no. I said that you have seen both lives, with the drug, without drug, which life is better? So 5 to 6, they say, because now their bladder capacity has become better by bladder training and by exercises. They are drinking less tea, coffee, so they are better. So we want to do that. Other, they want to go back on the drug. So we can again give the drug and another like 1 year, 2 years. So for 4, 5 years, I mean, some of my patient has taken for 5 to 6 years also, and occasional patient has taken 8 to 10 years also. But I keep them giving drug holiday for 3 to 6 months in between. And when it become non-manageable, I can give them again this thing. So that is, so thank you very much, sir. I think that is the last slide. Thank you.
Sir, thank you. That was a wonderful talk on the overactive bladder, and you gave a very practical suggestion and tips to all the practicing gynecologists. Wonderful, sir. Wonderful.
Thank you, sir.
I have the chairpersons who can conclude the
Yes, yes.
session.
Thank you, sir. The session was very informative.
Thank you.
I get lots of post-hysterectomy and menopausal ladies with urgent incontinence, and by reducing the weight, I can assure them. And I just want to know how it will help in reducing the weight. Sir.
Radiation inducement.
Weight reduction, how it will help in overactive bladder?
Yeah, but weight reduction, basically, abdominal wall and abdominal contents, they also become a little bit heavier, because in India, we have more of central obesity.
Yes, sir.
I mean, tummy gets bigger. So that puts pressure on the bladder.
Okay.
So just like pregnancy, during pregnancy or
Yes,
during
sir.
some fibroid patient, like you see, so they push bladder, and many patients of fibroid, many patients of cystosis, many patients of, during pregnancy have. So on the same basis, it also works. So I have
Yes,
seen
sir.
it that when they lose weight, man, it helps. It's not that
Yes.
that's not the only thing. If the patient has got severe incontinence, then again, just alone weight loss will not help. We have to do
Yes.
other treatments also.
Indirect effect as well.
Yes, partially.
Yes, sir.
Sir,
Usually
congratulations, sir.
post-hysterectomy and menopausal ladies will be obese only, sir.
Yeah, most of them
Yeah.
tend to gain weight. Yeah, that will
Yes,
work,
sir.
man. But you can give them one drug also, man. This solifenacin, derifenacin, plus bladder training, plus exercises, along with weight reduction, and also
Okay.
that is, yeah. So everything has to be given, man. One arm will not work.
Yes, sir. Yes. Thank you, sir. Thank
Yeah.
you very much.
Yeah.
Very informative session, sir. Thank you.
Congratulations, sir. It was a very nice, energetic and comprehensive talk, sir.
Thank you, sir. Thank you.
Sorry I joined late, sir.
No, it's okay, Dr. Rangnath. And I'm so happy you are doing such wonderful work at your place, Dr. Rangnath. I was seeing your CV. Yeah.
Yeah, thank you, sir.
Wonderful job, sir.
But I wanted to ask you one question, sir.
Yes, sir.
Sir, any acupressure or acupuncture therapy will work for this, sir?
Sir, I don't have personal experience of it, but I have read articles, some Chinese article and all. So they have some effect, but maybe you can have one, like, out of these 5 treatment, you still have to give, one of the drugs, derifenacin, sulfamycin. Along with that, we can do that also. Just like there is a treatment available. I didn't go into detail of that,
Nowadays,
in which way we stimulate the nerve, sir. Like, this leg
nowadays
nerve is stimulated.
neuromodulation is
Yeah,
completely-
neuromodulation. So on the same basis, it also works. There is a scientific evidence for that. So neuromodulation. I didn't go into detail of neuromodulation, botulinum, this thing, cystoaugmentation, because they are almost never done. So I have never done them. But I was in Croydon Hospital with this thing, and they were doing it, sir. The neuromodulation, and it works by. I just was wondering that how does stimulation of this soleal nerve or leg nerve will help in this thing. So basically, the impulse will go to the brain, and somehow, just like that, it will work on pudendal and those nerves also. So it has some efficacy, sir, definitely.
Yes. And any yoga, sir? Any particular yoga you advise?
Yoga will work like pelvic floor exercises, sir. In fact, I was surprised to see Dr. Ramani madam in King's College. There was a 1 hour session for the patient for pelvic floor exercises, and I was shocked to know that she was advising them yoga, and she was the breathing exercise. So what happens, sir, then when we are breathing in, diaphragm goes down, abdominal contents go down, and they touch the pelvic floor. So pelvic floor contacts, and then during exhalation, the pelvic floor rises up. So they say with each breath, the pelvic floor goes down and up. So you can do a lot of exercise. It came as a news to me also. I was so amused that in London they are using it, and in India we are not using it.
We are not using.
So that yoga also helps, sir.
Yes.
Shall
Then
we go
what
to the
about
next?
this TENS and all, sir? This electrostimulation.
Yes,
I
that's
think
my.
the physiotherapists are for that, and the postpartum exercise. They do that and they are getting a good relief.
It gives good results, absolutely.
Yes.
Yeah. For this webinar, I also welcome our Secretary of Kasoga, Dr. Shobha Gudi ma'am, and also the EC member, Dr. Rekha Rajendra Kumar.
Okay.
We will move on, with your permission, we will move on to the next.
Hello, Vijay. Hello.
I want to
madam.
say hello to
Good evening,
Shobha
madam.
Gudi madam. Shobha
Hello.
Gudi is madam, my very close friend. Shobha madam, good evening.
Good evening. Good evening. Very nice to hear you on a Kasoga platform. Wonderful,
Okay.
actually. And Dr. Sharma, you have really excelled in this subject. I was thinking, so much of subject expertise, and when we were working together as chair, I never had the chance to listen to you in such detail because I myself was talking most of the time.
Oh, no.
So now I thank Vijay for conducting this webinar, and Vijay, you are doing very good work for the subcommittee of Kasoga, and keep up the good work, and you and your team are very hard working. And I think Dr. Ramani also will agree with me. Hello, Dr. Ramani, good evening.
Yeah, good evening, Shobha. Good evening. Nice to see you.
Yes, same here. I was just saying that you will also agree with me that he has brought in many aspects into the therapy, and also he brought in so many jokes also.
Once again reminded me that I was sitting in a classroom, postgraduate
You need to
classroom.
make it interesting, otherwise people sleep, no? So they find it.
In Delhi, Jai Mataji is a very popular thing.
Thank you, ma'am. Thank you.
Shobha, you are muted. Shobha, you are muted.
Yeah.
Ah.
So I like the jokes also, and actually very lively atmosphere to learn urogynecology, which is a very complex subject. So thank you for building this ambience, and keep up the good work for Kasoga. Thanks for inviting me. And then I'll meet you all again. Yeah. Thank you.
Thank you, madam. We will go on to the next scientific program. That is the talk on the asymptomatic bacteriuria in pregnancy. We have a very eminent speaker, Dr. Ramani Devi, who is very popular among the pan-India. She is famous. So to introduce madam, we have the chairpersons. Can we have the chairpersons, Mr. Arun? Yeah. So we have Dr. Praveen S. Sajjanar, who is president of Gadag Society, Kasoga. He is done fellowship in laparoscopic surgery and a consultant obstetric gynecologist in Sanjeevani Hospital, that is in Gadag, Karnataka. He has completed MBBS and DGO from BLDE and DNB from Kamineni Hospital in the year 2018, completed fellowship in laparoscopic surgery as well. Can we have one more chairperson? Yeah, we have another eminent chairperson, Dr. Girija Sanjay, who is a consultant gynecologist at Dr. Mahadevappa Hospital, Tumkuru, and Madam is president of Tumkuru Society of Obstetrics and Gynecology and vice president of IMA Tumkur. I welcome you both, madam and sir, and I want you to introduce our eminent speaker, Dr. Ramani Devi, madam.
Thank you, sir. Hope I'm audible.
Yes, you are audible, madam.
Yeah. Thank you for inviting us as a chairperson, sir. It's
My
our pleasure to hear such informative talks and to introduce the speaker, second speaker of today's session. It's our privilege, it's my privilege. Professor Dr. T. Ramani Devi, President TNFOG 2024. She's the National Vice President of FOXY 2020. International Advisory Board member of Fertility Society of Bangladesh.
Dr.
ICU.
Girija, I think you can stop with that. You're wasting
Madam
your
has,
time.
yeah, Madam
all right.
has.
I think in front of Dr. GB Sharma, my work is nothing.
No, madam. Both of you are so eminent. It's
Yes,
our
yes,
privilege
it's
to
a
have
pleasure
you
to hear
both
it,
in for this evening.
Okay, thank you, sir. Thank you.
We would love to hear your talk, ma'am, on asymptomatic bacteria in pregnancy.
Yeah.
Welcome.
I'll start sharing my screen. You're able to see my screen, no?
Madam.
Okay.
Yes, ma'am.
Let me go ahead.
Make it slideshow, madam.
Yeah, I have already made it into a slideshow.
Yeah. Okay,
Yeah.
madam.
Okay, thank you, sir. Thank you for the kind invitation. And it is very happy to be with all of you, the Kasoga group, and especially with my dear friend, Dr. Shobha Gudi, Dr. Rekha Rajendra Kumar, Dr. Rajeshri Palladi, and the most respectful sir, Dr. JB Sharma. So the topic given to me is asymptomatic bacteriuria in pregnancy. Okay, so this the contents will be a definition, what are the risk factors, is screening and diagnosis an important one, and if at all we find anything, how to go about the treatment, and the impact of asymptomatic bacteria upon the maternal-fetal outcome, and can we prevent it, and what are the future directions towards research in this particular topic, and conclusions. So urinary tract infection is a bacterial infection that affects the parts of the urinary system starting from urethritis, cystitis, and it can ascend, leading to pyelonephritis. It is always, as the sir has said previously, it is an annoying disease with a painful syndrome. Always the patient has got an urge to pass urine, frequency, dysuria, and ultimately they become tired, and if it progresses, it may lead to pyelonephritis and sometimes septicemia. So the key aspects of ASB in pregnancy are, we should know what is the prevalence. Then, according to the various literature evidence, I found that it affects 2 to 20% of the pregnant women. But some of the Indian statistics show that even 30 to 40% of the pregnant women of belonging to lower socioeconomic group can be affected by asymptomatic bacteria. And hence screening becomes very much necessary. And many of the guidelines, they recommend screening all pregnant women for ASB, typically in the first trimester. But still, only screening in the first trimester is not enough, because still it can happen to 20 to 30% can happen during the second and the third trimester. Once if asymptomatic bacteria is detected, you have to prescribe antibiotics to eradicate the bacteria and later prevent the complications. So the types of UTI are, first is asymptomatic. So the patient usually comes to the antenatal period and we give a list of investigation which will include a urine routine. And when she brings us back the reports, we will find some bacteria and the pus cast and so many other things. So then the next thing is we will advise them to go for a urine culture and sensitivity. So that means The patient will say, I am a healthy pregnant woman, but you are branding me as a patient having UTI. So that is because the patient still has got no symptoms in spite of the infection, and it is caused by the bacteria that is present in the woman's system even before pregnancy has occurred. And if it is left untreated, it can ascend, leading to upper urinary tract infection. And cystitis, acute cystitis, it is the infection of the bladder or the urethra. And the symptoms, as I have mentioned earlier, is painful micturition or burning sensation, frequent urination, feeling of needing to urinate, and fever. See, all these symptoms mimic the overactive bladder, but as Sir has mentioned again, the subtle difference is only the growth of the bacterial organisms. Then pyelonephritis is the one. It has got a major impact upon the maternal and the fetal outcome. Usually the patient, they present with flank pain and pain or burning sensation during menstruation, frequency of urination, urge to urinate, and sometimes they are associated with hematuria, fever, and it may lead to adverse fetal and maternal outcome. For example, the patient may land up with preterm labor, severe infection, and adult RDS can happen. So, what is the definition of asymptomatic bacteria? ASB is defined as a condition where when you collect the midstream urine culture that shows a significant growth of bacteria that is more than 10 to the power of 5 colony forming units per ml in the absence of any symptom. That means the patient is totally asymptomatic, but the urine culture will show 10 to the power of 5 colony forming units. So then you do not rely upon the culture and sensitivity in a single occasion. Maybe sometimes you need 2 occasions it has to be done. And the global prevalence varies, as I said, 2 to 15%, or it may go even up to 30 or 40 or 50% in some of the African countries. So this was a study from AIMS Rishikesh, where they had studied the prevalence of asymptomatic bacteria. It was a systematic review and a meta-analysis where they have included nearly 20,000 participants, and the average prevalence is 13.5%, and it varies from 9.2 to 14.8% across central India to southern India. So that means in southern part of India, the prevalence is higher. And again, we have to see this paper also shows that asymptomatic bacteria is highest in the 3rd trimester. So hence, we need to screen the pregnant woman, preferably in each trimester. This is the place where we have to have a future research work, because many of the papers, they say just a single screening during the first visit or during the first trimester is enough for screening for ASB, but it is not so. So this was a pooled prevalence of ASB according to the parity and trimester. See, in a parity multiparous woman, it may range from 13.4, maybe in primary it is 15.6, and somewhere you have between 13 to 15. And trimester wise, as the trimester increases, like in many studies, they have shown that in the 3rd trimester, the incidence is about 21.8%. So this was again another paper from Nigeria, where they had included 1,228 pregnant women were recruited, and they had done a midstream clean catch. Sample was sent for culture, and urine sample was both they had done for a microscopic examination as well as a culture. See here, the incidence of ASB is found to be around 45.3%, and then with respect to age, the trimester did not show any significance. And the prevalence of the organisms mainly involved are E. coli, which is the predominant one, followed by Staph aureus. And the sensitivity to the drugs was ciprofloxacin, ceftriaxone, and augmentin. So in the conclusion of this study is, asymptomatic bacteria is not uncommon among the antenatal patient, and hence we need to do a routine urine culture sensitivity to all the antenatal patients so that we can reduce the maternal and the obstetric complications associated with pregnancy. So this is again the same, another study where age-wise they have studied, and they have found out it is beyond 26 years to 30 years the incidence was almost 50%. And as the age goes up, 41 to 45%, it is around 26. And in the younger age group, it is around 38%. So overall, 45.3% of the women are likely to have ASB. So, So then, trimester wise, when they have seen, again, almost there is an equal distribution. 45% in the first trimester, second trimester it is 48, and third trimester it is 40. So an average of 45% incidence they had. And the organisms were found to be E. coli and E. coli, Staph aureus, Klebsiella, Proteus, Citrobacter, Providentia, Pseudomonas aeruginosa, and then Candida. So it was not uncommon to see even Candida infection. So there can be a passage of vaginal Candida infection into the lower genitourinary tract. So then now we see, let us see what is the significance of asymptomatic bacteria. So we are all for doing routine urine microscopy and culture. Then why should we do it? Because if the asymptomatic bacteria is left untreated, it can lead to serious maternal complications like pyelonephritis, renal abscess, sepsis, DIC, and RDS. Not only that, resistant anemia complicating pregnancy may be because of the underlying urinary tract infection. Then again, coming to the fetal complication, the patient can land up with a preterm birth, premature rupture of membranes, anemia for the maternal anemia as well as fetal, low birth weight. Mental retardation can happen on a long way, and then developmental delay, intrauterine growth retardation, and IUD can happen. So screening and treating ASB during pregnancy is crucial for prevention of all these adverse maternofetal outcome. Hence, we need to screen and treat. If it is not treated, the patient can progress towards acute cystitis in 2% of the cases, and still 2% of the patients can go in for pyelonephritis, which will lead to hospitalization as very well. Neither the pyelonephritis can progress to septicemia at any time, especially in an immunocompromised status like pregnancy, and hence the patient has to be treated with intravenous antibiotics and adequate hydration. So now let us see what are the risk factors for asymptomatic bacteriuria. With increasing age and then poor socioeconomic group, parity, hemoglobinopathies are another reason why the ASB can be, incidence can be high, and history of urinary tract infection in previous pregnancies and immunocompromised states like diabetes and then HIV, and the presence of renal calculi is one important thing because it acts as a nidus for constant production of this bacteria, and it can lead to asymptomatic bacteria. And renal transplant patients, it is not uncommon nowadays to see patients coming with pregnancy in a post-renal transplant status. And I think it is ideal they have to be screened for urinary tract infection periodically, not in each trimester, but better to screen them every month. So then, what are the factors that can predispose to UTI during pregnancy? Because there is rhinomegaly, and there is compression of the bladder and the ureter, and there can be minimal hydronephrosis and hydrouretus during pregnancy because of the compression of the gravid uterus. And again, there can be incomplete emptying of the bladder, and urine is also less acidic during pregnancy. And again, sometimes the patient can have proteinuria, glycosuria, and because of the hormonal effects also, urinary tract infection is common during pregnancy. Again, some of the other factors are, hormonal factors are, progesterone-induced urethral dilatation is common. And as I mentioned earlier, mechanical compression of the gravid uterus, both will lead to increased residual volume of the bladder, causing urinary stasis. Not only that, there can be vesicoureteral reflux. This can lead to ascending infection. So then comes screening and diagnosis of ASB. Pregnant women have to be screened for AFC each trimester by culture and sensitivity. This has reduced the incidence of pyelonephritis from 25 to 30% to 1.4%. So that means it gives good relief from any sort of ascending infection and causing adverse maternal and fetal outcome. But some of the studies showed that only 2.2 to 2.4% of pyelonephritis in women not screened for ASB. So that means whether you screen these patients for ASB or whether you don't screen, the incidence of pyelonephritis is the same. So this brings us a thought whether we need to screen all these patients for ASB. So this may be a future research topic. Hence, US Preventive Services Task Force has downgraded routine ASB screening to evidence A to evidence B. So they are not US Preventive Health Services Health Task Force is not for doing a routine ASB. Then majority are for screening in each trimester. So, but a majority of other guidelines, NICE guidelines, and they don't have proper RCOG guidelines for that, but they depend upon the NICE guidelines. And then International Society for Urology, all those societies are for screening for every trimester. So this was our own study from Bhubaneswar, Odisha, Department of Microbiology, where they have found out what are the prevalence, risk factors, and the causative organisms in Indian scenario. They have taken 200 pregnant women over a period of 4 months. The prevalence was found to be 25.3%. Maximum prevalence was between the age of 21 to 30 during third trimester among the multigravida. The conclusion was undiagnosed, untreated ASB is associated with complications during pregnancy. Hence, routine screening of antenatal women with ASB for ASB during all trimester becomes a must. So this is our own study, and I think we can follow this. Each trimester, we have to go for screening for asymptomatic bacteria. And this was another study again from Kasturiba Medical College, Mangalore, where it was a quite an interesting study because in a low resource setup, whether every person need to have a every trimester culture and sensitivity. So what they have done is they have taken a midstream clean cat urine and subjected only to sediment microscopy. So they found out when the pus cells were greater than 5 per HPF, they found out that the culture sensitivity was positive. So they took this as this particular pus cells alone as a screening tool to find out the evidence of ASB just by doing a microscopic examination. So the result was ASB was present in 10.2%. The incidence was higher in 20 to 30 years, similar to the previous study, and gravida 3. So multigravida, it was high, and upper, lower, and lower socioeconomic group, and in patients who were having diabetes and anemia. And here again, they showed that E. coli was the commonest organism, and they had poor sensitivity to amoxicillin, ampicillin, and nitrofurantoin, and good sensitivity to cephalosporins and amino acid glycosides. See, but generally what we do is when we see a patient with urinary infection, asymptomatic bacteria with a lot of pus cells, then we immediately start the patient on nitrofurantoin. That is the routine trend, 100 milligram BID dose. But this particular study says that it has got a poor sensitivity. And again, sensitivity, specificity, positive and negative predictive value for urine microscopy was found to be 43%. See, 85% of specificity, and again, negative predictive value was very good. So this can be taken as a model where we can rely in a low resource setup doing only the culture sediment microscopy. And if the pus cells are greater than 5 per HPF, we can treat it, take it as ASB. So then again, the accuracy of urine analysis to predict culture positive treatment, urinary tract infection. Here they have done a dipstick as well as a microscopy. In the dipstick test, leukocyte positive means it gives a sensitivity of good sensitivity of 72 to 97% and a negative predictive value. So the nitrites, again, it has got a good specificity and good negative predictivity. Leukocyte esterase and nitrates together, they had shown a negative predictive value, which was quite high. And again, it has got a sensitivity, variable sensitivity. And protein 3 plus or more than even 1 plus, it signifies that the probability of this particular patient having UTI is quite high. Then microscopically, this again, the apart from the 5 WBCs per HPF and more than 5 RBCs per HPF, apart from the bacteria of any amount, we should take into consideration the patient may be suffering from asymptomatic bacteria. So now let us see what the National Institute for Health and Care Guidelines Excellence have said and Infectious Disease Society of America has said. So they said that RCOG along with NICE and IDSA recommend screening for ASB in all pregnant women, typically with a urine culture at the first initial antenatal visits. In summary, while RCOG does not have specific standalone guidelines for ASB, it is relying on NICE. It refers to other guidelines and resources for the management of ASB in pregnancy, emphasizing against screening, appropriate antibiotic therapy, and careful consideration for the potential risk and benefit. So then again, this was another study where asymptomatic bacteria and bacterial interference, this is from a microbiological journal, where they have found out of 145 untreated pregnant women, less than 32 weeks, whom the bacteriuria was identified in positive 3 cultures, they found out that 14% still cleared spontaneously during the remainder of the pregnancy. But you see, 70% they remain bacteriuric, and 27%, that is 27 out of this 145, that is 16%, develop pyelonephritis. Then another study where 106 women, they were subjected to 3 consecutive urine specimens, and they found out that 63% remain bacteriuric and not untreated throughout the pregnancy. Only 9% cleared spontaneously. In this study, 14% cleared. Here it is 9%, while 26 out of 106 had developed symptomatic infection. So there are chances that the patient can clear off spontaneously, but majority of the patient, they remain bacteriuric, and around 16 to 28% of the patient may develop upper urinary infection, including pyelonephritis. So they need to be treatment. So then the next question is, how often we need to screen for ASB? The US Preventive Services Task Force has mentioned that every 12 to 16 weeks or during the first visit, you have to screen. The Canadian Task Force on Preventive Healthcare suggests screening at first trimester. And there was no repeat screening advice after the initial treatment. That means if you do the urinary culture sensitivity in the first visit, and if you treat them, there is no need for screening after the initial treatment. This was one school of thought. But whereas you look at the other one, the ACOG, that is ACOG consensus recommendation, again, they also recommend at first visit. And here they say the repeat screening during or after a negative culture sensitivity, there is insufficient evidence. So they also recommend that if there is an initial culture is negative, there is no need to subsequently screen for ASB during pregnancy. So the treatment they suggested was 5 to 7 days course of proper targeted antibiotics if they have a 10 to the power of 5 colony forming units per ml, and there is insufficient evidence to recommend for against repeat screening after appropriate treatment. So one school of thought says, if it is negative in the first visit, don't do anything. And even if it is positive, treat them with appropriate antibiotics, then there is no need for repeat screening. So again, this I can skip because I am not discussing about the cystitis and the pyelonephritis, which are totally different, that we have to have definitely treat the patient when they have symptoms with the appropriate antibiotic, and they need to have a repeat urine culture. And sometimes there is recurrence of UTI in pregnancy can also happen, in which case the patient can be treated with a low dose antibacterial therapy. For example, the patient can be started on low dose of nitrofurantoin 50 to 100 milligram per day, every day, or sometimes if the urinary tract infection occurs following intercourse, maybe a single dose of antibiotics can be preferably given after sexual activity. So this was about the pyelonephritis. These patients, the most important thing is they have symptoms, and they have general symptoms and the localizing symptoms, and they have to be treated as an inpatient setting. Appropriate antibiotic should be given after the urine culture sensitivity But prior to that, you have to start the patient on empirical antibiotic therapy. Mind that here, the intravenous or parenteral antibiotic therapy should be given for a period of 14 days. Then, insufficient evidence to guide the management and treatment of pyelonephritis in pregnancy, and clinician may consider suppressive therapy for the remainder of the pregnancy or as for recurrent UTI. So the common organisms we have seen in the previous papers, E. coli is the commonest one, Klebsiella, Proteus, B. streptococci, chlamydia, and gonorrhea. See, these two are gaining more important because most of the organisms are E. coli, but beta hemolytic streptococci, when it is found to be positive, even after treatment, it is always safer to have a coverage during delivery. Then treatment is, we have discussed already, it should be given for a period of ASB, should be treated for a period of 5 to 7 days minimally. Not treating them for 3 days is sufficient. And there is no need to repeat culture according to the Infectious Society of USA. And again, to begin with, you can start the patient with nitrofurantoin 100 milligram TDS. Cephalexin can also be used, but alter the drug according to the sensitivity. 5 to 7 days. And otherwise, a single dose of phosphomycin can also be given, and better don't use ampicillin and amoxicillin because E. coli is found to be resistant to these drugs in most of the cases. Then role of beta streptococcus in UTI. Even in low colony count, if it is positive, prophylaxis is advised during labor. Normal vulvovaginal flora like lactobacillus, cardibacterium, and coagulase negative streptococci need not be treated. So because they are all commensals. So this is a table to show what are the antibacterial drugs. See here, nitrofurantoin, we have explained, cephalexin and phosphomycin, no amoxicillin and ampicillin, and sulfamethoxazole with trimethoprim. So it is reasonable to offer in the first trimester if no appropriate alternatives are available. Otherwise, I don't use any sulfa group of drugs during pregnancy. Then again, the next paper is from a tertiary care center where it shows, again, an Indian study, asymptomatic bacteria and antibacterial susceptibility pattern. So here, they have found out 2 to 11% of the pregnant women suffer from ASB. And then the result, when they screen 250 patients, the common organism was E. coli as expected, followed by Klebsiella and Staphylococcus aureus. And majority of the uropathogens were sensitive to nitrofurantoin in 81% and ciprofloxacin in 63%. Again, we know we don't use ciprofloxacin during pregnancy. So the conclusion is, the high prevalence of ASB among pregnant women is 10.8% in their center, that demands the need for routine screening of pregnant women and treat with appropriate antibiotics to prevent the complication. So this is according to the NICE and the IDSA treatment should be 5 to 7 days, and then avoid resistant, should be amoxicillin and ampicillin should be avoided, preferable nitrofurantoin, trimethoprim better to avoid in the first trimester, and follow up. Repeat urine culture should be performed 7 days after treatment to confirm the eradication. So again, there is a controversy whether to do it or not to do it. Then how to manage recurrent UTI? Recurrent UTI occurs in 4 to 5% of the cases, and mostly in immunocompromised patients, especially in diabetic patients, very obese patients, or patients on immunosuppressive drugs, or HIV positive patients. So the recurrence means there is 2 to 3 times presence of UTI during pregnancy, and prophylaxis is low-dose antibiotics following coitus, or it can be given throughout pregnancy. If the, as I have mentioned earlier, if it is post-coital, then you can give the low-dose antibiotics following coitus, or it can be given throughout if it is irrespective of intercourse. Then here, nitrofurantoin and cephalexin can be given as a low-dose one. So now there is an European journal which says, what is the association of ASB in pregnancy and the adverse effects upon the mother and the fetus? Here they showed there is an increased risk of chorioamnionitis, premature rupture of membranes, and there was a diverging results as seen between preterm labor, low birth weight, and small for gestational age. So the conclusion was there is a need for more recent high-quality studies to investigate the association between untreated and treated ASB and pregnancy and the birth outcomes to assess the impact of E. coli and GBS on these assessments. So they were having two controversial results, but in general, the incidence of pyelonephritis can lead to PROM, preterm birth, low birth weight, and small for gestational age. In some of the studies showing a significant p-value, and some of the studies are not for it. So now let us see, apart from the antibiotics, are we justified in giving some adjuvants? One is always urinary alkalysis will help because the urine is, most often it is acidic during pregnancy, cranberry extract, D-mannose, which will prevent the clinging of this E. coli to the bladder mucosa. Probiotics can be given. Tropical estrogen, it may not be suited for this situation. And again, immunomodulatory agents and NSAIDs can also be given for relief of pain and good hydration so that all these E. coli and all the bacterial organisms are being washed away. So how to prevent urinary tract infection? Drink plenty of liquids. It is in contrast to my previous speaker who says limit the fluids to reduce the overactive bladder and urinate promptly. Avoid potentially irritating feminine products like antiseptic creams, feminine hygiene sprays, powders, and keep the genital area clean. Just a simple wash with clean water is sufficient. There is no need to use soap or anything. And apart from this, the end of my talk is what will be the future direction? Where all we can go for research. Research is for developing screening frequency. This is a gray area because some guidelines are saying that we have to screen every trimester, but some are not for it. Then exploring the different treatment, 3 days versus longer treatment. I think now we have the fixed protocol of minimum of 5 to 7 days. Need for repeated culture sensitivity, management of recurrent UTI, low dose long-term antibiotics, and management during postpartum period is also very, very important because postpartum UTI is also likely to happen. And it is one of the important reasons for causing febrile morbidity. Again, the patients on indwelling catheters are a special group where they are invariably symptomatic, and we have to have a future direction should show some light upon this. So this was an algorithm. If urinary symptoms, no, it is significant bacteria is present, means it is asymptomatic bacteria. Then if there is no significant bacteria is present with the urinary symptoms, it's like dysuria, urgency, frequency, and nocturia, hematuria, and suprapubic discomfort, and they can be associated with systemic symptoms like fever, nausea, rigor, vomiting, and renal tenderness. It can be associated with no acute cystitis. They may have pyelonephritis. All these patients with asymptomatic bacteria having a colony count of greater than 10 power 5 in voided urine, they should be treated. Or symptomatic bacteria with the E. coli, even with a count greater than 10.2, or non-uropathogens when the colony of greater than 10 power 5 in the voided urine, they also need to be treated. And again, so finally, screening all antenatal women at 12 to 16 weeks with urine culture, then confirm the diagnosis of asymptomatic bacteria. If it is positive, treat the patient with nitrofurantoin or cephalosporin or phosphomycin. Repeat urine culture after 1 week after completion of the treatment. If it is negative culture, further treatment if the patient may need chemoprophylaxis or not. And if it is a repeat positive culture, it may be the same organism or it may be a different organism. And hence, we have to choose the antibiotics according to the culture and sensitivity. And here again, they say the test of cure is not recovered. So my conclusions will be pregnant women with ASB have increased risk of pyelonephritis. Antibiotics reduce the risk. There is a controversial relationship between ASB versus preterm birth with low birth weight. And we need, there is a role of E. coli and group B streptococcus upon fetal-maternal outcome has to be studied. Research is needed to find the risk of birth complications upon treating ASB or not. But whatever it is, still we need to treat ASB. And the education is the most powerful weapon which you can use to change the world. So thank you for the opportunity given to me. Thank you, sir.
Thank you, madam. Thank you, madam. It was so informative and a different perspective view about the asymptomatic bacteriuria. It's not just the usual asymptomatic bacteriuria, which all has to be considered and which all has to be treated further. I request chairpersons to put up the concluding remarks.
Very informative talk, ma'am. You covered every aspect of ASB in pregnancy. As we all know that pregnancy is prone for urinary tract infection, and screening in every trimester would be a better option. And because asymptomatic bacteria, as you told, may lead to some many renal pyelonephritis, which leads to many of the maternal and fetal adverse outcomes. How it will reduce from 20 to 30% to 1 to 4%. Very informative. And also, now we are going with take-home tips of when to do the test, how often to be done, what antibiotics to be used. Wonderful talk, ma'am.
Thank you.
Thank you so much.
Yeah. And one more point, madam. Actually, I wanted to tell to the other delegates also. Nowadays, in my experience, phosphomycin has become very useful.
Yes.
It's a single dose agent, and we can ensure that the patient takes phosphomycin in my clinic only, so that I will be rest assured that our asymptomatic bacteriuria or even the one episode of cystitis will be taken care.
So then for recurrent UTI,
Yes.
resistant cases, sometimes I use phosphomycin weekly once. 3 doses to 6 doses. That also helps in clearing them totally.
Right.
And I am of the opinion that phosphomycin should be given at bedtime after completely emptying the bladder. But that was the instruction given to me, but instruction given in the by the pharma company. I don't know whether we are justified in giving it. But
Yeah.
one thing we are assured is the patient has taken the drug completely.
True,
If she is
madam.
given during the hospital visit itself.
Right. And I thank both the speakers for the wonderful talk. And we had a nice scientific webinar this evening. We have Dr. Shreya, our the member of the committee, who can give the vote of thanks. Over to you, Dr. Shreya. And before that, I wanted to inform all the delegates that due to the other Yuva Kasoga conference, our president, Dr. Durgadas, is not available for this webinar. Otherwise, we had our secretary, our treasurer for this evening webinar. Over to you, Dr. Shreya.
Thank you, sir. Thank you, sir. Good evening, everyone. On behalf of the Urogynecology Committee of the Kasoga, this opportunity to extend my sincere and heartfelt gratitude to everyone who has made today's session a great success. First and foremost, a sincere thanks to you for our esteemed speakers, Dr. J.B. Sharma, sir, for his insightful and practical session on overactive bladder. Sir, your expertise and imagery with words was enriching for us all, sir. And also, I would like to extend my sincere gratitude to Dr. Ramni ma'am for the informative talk on asymptomatic bacteriuria and shedding light on this often overlooked yet clinically very important yielding topic. We are also grateful to our chairpersons, Dr. Rangnath sir, Dr. Vidya madam, for their expertly moderating the first session. I extend our gratitude to Dr. Girja Sanjay ma'am for her thoughtful stewardship of the second session. A special mention and sincere thanks to our esteemed chairman of the KSOGA Urogynecology Committee, Dr. Vijay Kumar CR sir, whose leadership continues to guide us and strengthen our academic goals. And we are also grateful to Dr. Aarti ma'am, the secretary of the Urogynecology Society Committee. And we're also ever thankful to our KSOGA patrons, Dr. M.G. Hiremat sir and Dr. Nagraj sir. Your wisdom and continued support are like a beacon of light for us in our academic endeavors. And also, I would like to extend our deepest gratitude to Dr. Durgadas Asrana sir in his absence, and to our secretary, Dr. Shobha Gudi ma'am, and EC member, Dr. Rekha Rajendra Kumar ma'am. for their constant encouragement, and for even in their busy schedule to coming and providing us a platform for this academic growth and fostering this collaboration. And also a heartfelt thank you to all the delegates and participants who has joined us today, and your enthusiasm and presence made this event more memorable and worthwhile. And with that, we conclude today's academic proceedings. Thank you once and all.
And last but not the least, I also thank our Mr. Arun Kumar, who has coordinated this webinar so wonderfully.
Yes.
Thank you all for your
Thank you, everyone. Thank you, Dr. Arun.
Thank you. Thank you.
Thank you.
Thank you, Vijay Kumar sir, for making me a part of
My
this.
pleasure, madam. My
Thank
pleasure.
you, thank you. And my
Vijay
best
Kumar sir,
wishes
thank
to
you.
Dr. Rekha for
Thank
her
you.
success in her election.
Thank you, sir. Thank you.
Okay.
Thank you, madam.
Thank you.